Hey, good morning, everyone. Welcome to Wednesday morning cardiology rounds. Today we're going to have two presenters, Dr. Andrew Mulloy and Dr. Juan Russo, who are each going to present a trial from the ESC. Dr. Mulloy is going to present the INVICTUS trial looking at anticoagulation strategies in AFib patients with rheumatic valve disease. And Dr. Russo is going to present the revived BCIS-2 trial looking at revascularization strategies for ischemic LV dysfunction. So thank you to both of them. Andrew's going to present first, so I'll turn over the presentation to him. Welcome, Andrew.
Thanks, Ellie, and thanks everyone for coming this morning. Ellie, can you hear me okay? Is everything coming through all right?
Yes, we can. Everything is fine. I can see your slides.
Perfect. So as Dr. Stadnik mentioned, I'm going to be talking a little bit about the INVICTUS trial this morning, which was presented at ESC, which, as she mentioned, is a trial looking at rivaroxaban and rheumatic heart disease-associated atrial fibrillation and atrial flutter. INVICTUS is the first large randomized trial of its kind looking at this patient population that was largely excluded from other trials looking at DOACs versus vitamin K antagonists. And it looked at patients who have rheumatic heart disease and atrial fibrillation. So they were assigned either to take rivaroxaban at a dose adjusted to their renal function or a vitamin K antagonist to a target INR of 2 to 3, which would be assessed no less than once a month. So patients would have been seen once a month after randomization and every 6 months thereafter while they were in the trial. Ultimately, they recruited over 4,500 patients for the trial, although a small percentage of them were lost to follow-up for a few reasons. Patients had to be 18 years or older. They had to have echo-proven rheumatic heart disease, and they had to have been diagnosed with atrial fibrillation or flutter at any time. So it didn't have to necessarily be permanent. It could be paroxysmal or persistent. In order to be considered for this trial, they also had to have at least one of another 3 risk factors for stroke in the setting of atrial fibrillation, that being a CHADS-VASc score of at least 2, significant mitral stenosis with a mitral valve area of less than 2 centimeters squared, or spontaneous contrast or left atrial appendage or left atrial thrombus seen on echo. Initially, they planned on having a primary efficacy outcome of stroke or systemic embolism. This is the same outcome that was used in ENGAGE, in Aristotle, in ROCKET, in RELY, and so it made sense to use it as their primary outcome. That being said, during a blinded review by the steering committee midway through the study, they found that they had a much lower than expected stroke rate and a much higher than expected mortality rate. And so the steering committee advised, again in a blinded fashion, that they change their primary efficacy outcome to a combination of stroke, systemic embolism, myocardial infarction, death from vascular causes, and death from unknown causes. The logic there being that the presumption was that most death from unknown causes in the study would have been vascular in nature. They continue to keep stroke and systemic embolism alone as a secondary outcome, as well as adherence to rivaroxaban therapy. And then their primary safety outcome was major bleeding as defined by the International Society of Thrombosis and Hemostasis, which is a fairly straightforward definition, including bleeding into major organ systems, bleeding requiring transfusion. The average age of the population enrolled here was 50.5, and 72% of the population was female. We'll discuss this a little bit closer to the end of this sort of review, but it's obviously quite a bit different than a lot of the other atrial fibrillation trials, and to be expected that these patients with rheumatic heart disease would be on average younger and on average more likely to be female than in other trials. When it comes to the specific 3 criteria that patients had to meet or one of in order to be enrolled in this trial, you can see the majority of patients had mitral stenosis with a reduced mitral valve area, 82% of all patients. The number I would draw your attention to, and we'll talk about it a little bit later, is that in 15% of cases, the only additional criteria that patients met in order to justify enrollment was a CHADS-VASc of at least 2, so they didn't have significant mitral stenosis. And then a small percentage of patients had spontaneous contrast or left atrial thrombus. And when you do the math, it was less than 5%. Where this was the only criteria that justified enrollment for these patients. They followed these patients for a mean follow-up of 3.1 years. This was an outcome-driven trial. The majority of patients on a vitamin K antagonist were using warfarin, and their percentage in the therapeutic range was comparable to that of other trials looking at VKAs versus DOACs, sort of in the 60% range for time in therapeutic range. Adherence to rivaroxaban was lower than expected, with a mean adherence rate of just about 84%. That being said, the majority of people who stopped taking the rivaroxaban did so because they were moved on to requiring valve surgery during the course of the study and switched to a vitamin K antagonist. That being said, the second most common reason patients discontinued rivaroxaban was patient preference, and the majority of those patients were switched to a vitamin K antagonist. The outcomes of this trial were unexpected and quite a bit so. So when we look at the survival curves for the primary outcome, which I'll remind you again, stroke, systemic embolism, myocardial infarction, death from vascular causes, death from unknown cause, there was a statistically significant increase in this primary outcome in patients taking rivaroxaban over those taking vitamin K antagonists, and about 2% in terms of the absolute risk increase in patients who were taking the DOAC. When you break that down into some of its larger component parts, you can see that the trend in increase in stroke and systemic embolism on a DOAC was actually not statistically significant. Now, the study was not powered to delineate this after they changed their primary outcome. But the increase in death in patients who were taking the DOAC over the vitamin K antagonist was statistically significant. It was driven in large part by sudden cardiac death and mechanical or pump failure. Worth noting as well, when we look at these, of course, because we're talking about a study in which a significant percentage of patients discontinued their trial drug, is that they did both an intention to treat and an on-treatment analysis, and the results were similar in both groups. So failure to adhere to the study drug alone was not enough to drive this outcome. Looking at the safety outcomes, the difference in bleeding, in major bleeding between the two groups was not statistically significant. There was a statistically significant increase in fatal bleeding in the group who was taking a vitamin K antagonist. But of course, if you go back and look at the overall mortality curves, the net mortality benefit was still there for the vitamin K antagonist over rivaroxaban. So the primary conclusion that can be drawn from this is that in this very specific patient population, use of a vitamin K antagonist instead of rivaroxaban results in a lower risk of this combination of outcomes. And that risk reduction is largely driven by a reduction in mortality with using vitamin K antagonists instead of rivaroxaban. Worth noting that this is not simply rheumatic heart disease, this is rheumatic heart disease and one of a number of other risk factors. And we'll talk a little bit about what that might mean for the guidelines in a second. The biggest question mark coming out of this study is what role did the study drugs have on the effect of mortality between these two groups? So when we look at another study comparing rivaroxaban to vitamin K antagonists in ROCKET, there was no statistically significant difference in the mortality between the two groups. And in fact, if anything, the absolute value for mortality was lower in the rivaroxaban group. That being said, I've put them both here. The mortality rate between these two studies was dramatically different. So, between 6 and 7.5 in the INVICTUS trial and around 1.9 to 2.2% in ROCKET. So clearly there's a difference in the overall mortality, which makes it hard to compare these studies one-to-one. It's been proposed that one of the reasons for mortality benefit with vitamin K antagonists over rivaroxaban might be that simply having to go get their INR checked meant that these patients were in contact with the medical system much more than they otherwise would be, which allowed for better optimization of their comorbid disease. The study was not granular enough to sort of do this analysis in a statistically significant way, but it is a potential explanation for what's going on. And as I mentioned, we can't simply attribute this to a lack of compliance with DOAC therapy, because when we do the on-treatment analysis, the results are very, very similar. I think it's worth comparing the group that was studied in INVICTUS to the groups that were studied in other major DOAC versus vitamin K antagonist trials, because in this setting the results might be unexpected, and it's absolutely possible, and in fact I would argue likely, that the difference that we're seeing in terms of stroke, systemic embolism, although not statistically significant, could be reflective of just a difference in underlying pathology. It might be the case that patients with rheumatic heart disease simply behave differently. It's been proposed that they have differences in terms of the atrial endothelium that might predispose them to clot formation. It might be that they activate the coagulation cascade differently in the setting of rheumatic valve disease, which might mean that the DOAC is less effective. That being said, the difference may also be attributable to a difference in the patients who were studied. The patients in INVICTUS were significantly younger than the patients in other DOAC versus VKA trials, and significantly higher percentage of them were female. When we talk about patient region or patient ethnicity, I'll sort of highlight here that in Aristotle, Rocket, and Engage, the numbers I've given here are patient region and the region that they were recruited from, versus in INVICTUS, the numbers that they refer to patient ethnicity as self-reported. That being said, INVICTUS recruited almost exclusively from Asia, Africa, and the Middle East, versus Aristotle, Rocket, and Engage, which largely recruited from North America and Europe. So we are talking about a different patient population. We're talking about different regions. We're talking about different medical systems. And a lot of that may be responsible for the unexpected outcomes that we saw. In terms of how might this impact us in terms of our day-to-day care, largely this trial supports what's been written in the guidelines as it pertains to the treatment of patients with quote-unquote valvular atrial fibrillation, which, of course, as you know, is a term that has changed in terms of its definition over time. But as currently defined by the CCS and AHA atrial fibrillation guidelines, it includes patients with atrial fibrillation and either a mechanical heart valve or moderate to severe mitral stenosis. What's worth mentioning, and I alluded to this earlier, is that in INVICTUS, 15% of the patients enrolled in this trial were only enrolled because they had atrial fibrillation, rheumatic valve disease, and a CHA2DS2-VASc score of 2, but did not have significant mitral stenosis. And so by current guidelines, at least if we were applying the atrial fibrillation guidelines, the valve guidelines are slightly different. These patients would be eligible for DOAC therapy under the current wording. It's not clear because the study wasn't powered to look for this, whether this 15% of patients was part of the group that would have had a mortality benefit with a VKA over rivaroxaban. So I'm going to end things there because I imagine that there's going to be a lot of discussion around the study that Juan's going to present, but thank you so much.
Thank you, Andrew. I think if there's any questions right now for Andrew, we could entertain those now. Otherwise, we can address them at the end of the presentation, but we do have some time to answer any questions if anyone in the audience has questions. You can raise your hand and we will unmute your microphone. If not, we'll delay discussion for either trial until the end of rounds this morning. So we'll move over to Dr. Russo, who's going to present the revived BCIS2 trial. So Juan, go ahead and share your screen. I think you might be muted.
Yeah, can you see my screen, Dr. Stanek?
Yes, I can. Thank you.
Perfect. So thank you for the opportunity to present. So I'll be presenting the results of Revive BCIS2 randomized control trial, which has created a lot of discussion related to the management of patients with heart failure. So the objectives of the talk are to briefly review the results of Revive, to highlight early frequently asked questions that have come up in conferences, and then to have an open discussion as to how the results of the trial may guide our management of patients with LV systolic dysfunction. So previous evidence, mostly observational evidence, suggested that in some patients with left ventricular systolic dysfunction, that coronary revascularization resulted in an improvement of ejection fraction. And this led to the concept of viability in hibernation. In the STITCH trial, which is now more than 10 years old, the incidence of death from any cause at 5 years was comparable in patients randomized to CABG versus medical therapy. However, they noted that there was an increased risk of periprocedural events in patients with CABG, And therefore, it took some time for patients that have been randomized to this arm to accrue some of the benefits of revascularization. It was noted that the Kaplan-Meier curves in the STITCH trial diverge after 2 years. And therefore, the STITCH study looked at the survival benefit of CABG during a prolonged follow-up. In the 10 years, all-cause mortality was lower in patients with CABG at 59%, compared to patients with medical therapy at 66%, with a number needed to treat of 14. Therefore, the investigators of REVIVE hypothesized back in 2012, 2013, that maybe PCI could allow for some of the benefits of bypass without the early hazard associated with an invasive procedure, particularly in the context of patients who had ischemic left ventricular systolic dysfunction. And for this reason, they organized the REVIVE trial. To summarize some of the patient characteristics, patients needed to have a left ventricular ejection fraction of 35% or less. They needed to have extensive coronary artery disease defined as a BSIS Jeopardy score of greater or equal to 6. And they wanted patients to have demonstrated viability at least on 4 myocardial segments that were both dysfunctional and also amenable to PCI. These patients were then randomized to optimal medical therapy alone versus optimal medical therapy plus PCI. And the primary outcome was all-cause mortality, hospitalization for heart failure during a mean follow-up of 2 years. It's important to note that certain patient characteristics led to inclusion. Importantly, patients with a myocardial infarction within the last 4 weeks prior to screening were excluded, as well as patients with a recent heart failure decompensation or a sustained ventricular arrhythmia. So the investigators estimated that with a primary outcome event rate of approximately 43%, they would need 700 patients to provide 85% power to detect a hazard ratio of 0.7 at a 5% significance level. They randomized patients between 2013 to 2020. And when we look at patients' characteristics, we see that very similar to other trials, the mean age of patients was 70 years of age. Patients were predominantly male, and they were also predominantly white. One of the important patient characteristics of patients in the REVIVE trial, as opposed to other trials, including STITCH, was that patients in the REVIVE trial were minimally symptomatic. So more than 70% had NYHA functional class 1 or 2, and more than 2/3 of patients had no angina at the time of randomization. The mean left ventricular ejection fraction was 27% in both groups. So the main results of the trial were published in the New England Journal of Medicine and discussed in ESC, and they showed no difference between optimal medical therapy compared to optimal medical therapy plus PCI in the composite of death or hospitalization for heart failure during follow-up. These results were analyzed in relation to important patient subgroups, and visually we cannot see any significant heterogeneity in treatment effect in relation to these important clinical variables. When we look at secondary outcomes, we see that death from any cause was also comparable in patients randomized to PCI versus medical therapy, as was the rate of hospitalization for heart failure during follow-up. We do see that there's a higher rate of spontaneous myocardial infarction in patients who are randomized to optimal medical therapy compared to PCI, but this was counterbalanced by a higher rate of periprocedural events in the cohort of patients undergoing PCI, and therefore the rates of acute myocardial infarction during the period of follow-up was no different between the two arms. We also see that there was a higher rate of unplanned revascularizations in patients with the optimal medical therapy arm, with about 10.5% of patients undergoing some form of revascularization, mostly PCI, but also 22% of patients undergoing bypass. This rate of crossover is one of the limitations of this and many other trials of interventions, but the rate of crossover is not out of keeping with other previous trials examining revascularization. When we look at the ejection fraction, we find that there was no difference in echocardiographic estimates of ejection fraction at 6 months or 12 months between the optimal medical therapy and PCI arm. And then we look at quality of life based on the Kansas City Cardiomyopathy Questionnaire. We see that PCI patients had improved quality of life at 6 to 12 months, but there was a catch-up period with optimal medical therapy such that at 24 months, the differences were no longer statistically significant. So the authors concluded that in patients with a left ventricular ejection fraction of less than 35%, extensive CAD as based on the BSIS Jeopardy score and some viability, that the addition of PCI to optimal medical therapy did not result in a lower incidence of death from any cause or hospitalization during the period of follow-up, no incremental improvement in left ventricular ejection fraction, and no apparent sustained difference in quality of life during follow-up. So those basically highlight the main results of the revived trials. I wanted to quickly highlight some early questions that have come up in the trial, and then maybe leave some time for discussion. I'm not sure, Dr. Stadnik, whether I should do that first or allow people to ask questions related to the trial.
No, Juan, I think go ahead and finish your presentation, and then we'll open it up for discussion for both trials.
Okay, so important to note, the results of the trial were presented at ESC. They were then discussed in detail in TCT, and there's still some important subgroup analyses that are coming. So there are some sub-studies that will be presented in AHA in November. And there's some important analyses that are expected in the first or second quarter of 2023, as per the revived authors. So one of the important questions that was asked was what kind of patients were randomized to revive? So in conferences and in social media, people asked the question, in 2014 and 2018, the ESC guidelines would have deemed there to be an indication for revascularization in this patient population. So were patients randomized to revive patients that were turned down for surgery because of different reasons, high risk or no evidence of any good distal targets, or were there patients that were randomized to revive for other reasons? For example, they did not want surgery, or they were minimally symptomatic, and therefore there was no presumed benefit to be gained from revascularization. The trial does not necessarily highlight whether a surgical turn down was required explicitly in the protocol, but people that have spoken to the authors have deemed there to be a significant amount of patients who were actually enrolled as there were required to be surgical turn down. So there is a body of evidence that's analyzing whether patients who are turned down for CABG would benefit for PCI. Prospective observational study Optimum was presented last year, and the publication is still pending. But the reason for bypass ineligibility is not only a decreased ejection fraction, but other characteristics such as risk, et cetera. So this is an important question, whether patients were surgical turn downs or not. The other thing is that patients are required to have extensive coronary artery disease, and this was done as per the BSIS Jeopardy score. One of the things that was noted in the trial is that most patients in the trial, more than 50%, had only 2 vessel disease. And therefore, some of the investigators and some of the people reviewing the trial wonder whether in people with an ejection fraction of a mean of 27%, whether two-vessel disease could actually explain all of the left ventricular systolic dysfunction, or could there have been coincidental coronary artery disease in patients with left ventricular systolic dysfunction. Now, another question that has come up is, how should STITCH be interpreted in the context of the results of REVIVE? The easiest answer is that these are two completely different trials, apples and oranges. They're different in the most obvious way because the intervention is different. So even though both bypass and PCI attempt to revascularize myocardium, there's mechanistic differences between both interventions that have been well described. The other ways in which STITCH and REVIVE are different is that the patient population was much different, or was very different in both trials. So in the REVIVE trial, patients were older. They were 70 years of age as opposed to closer to 60 years of age in patients with STITCH. The patients with STITCH were more symptomatic than patients with REVIVE. The STITCH trial did not require viability. Some of you may recall viability was an initial part of the inclusion criteria in STITCH, but this limited enrollment, and therefore the investigators decided to remove viability as an inclusion criteria in order to increase enrollment rates. So approximately 50% of patients in STITCH had viability studied. Now, the other reason or the other way in which the two trials are different is in the comparison arm. So in patients with REVIVE, the ARNIs, MRAs, as well as SGLT2 inhibitors were more predominant. As you will recall, STITCH was published before the results of the Paradigm trial and before the results of DAPA-HF. So there is the possibility potentially that the control arm may have become better as the therapies for advanced heart failure have progressed. One of the things that people comment is that STITCH took 10 years to find a clinical difference or a difference in mortality between both treatment arms, and therefore that REVIVE should also have longer follow-up to determine whether this difference will also occur. I think the long-term results of REVIVE will be important, but it is not a similar scenario compared to STITCH, based on the fact that, as you can see in this curve, these are the Kaplan-Meier's curves of STITCH. You can see in the thicker curve, which is bypass, that there was an excess in death from any cause early in bypass, but that the two curves converge at 2 years and then diverge as the trial goes on. This is not the case for REVIVE, where the curves were actually superimposed on one another throughout the entire study period. So unlike REVIVE, there was some impetus to follow up patients long-term in STITCH to see where this divergence of the Kaplan-Meier curves led. That same rationale is not present in REVIVE. With that said, long-term follow-up is important. The other thing that has been brought up is the clinical relevance of viability in hibernation in the context of REVIVE. As you know, like the whole point why we're revascularizing these patients is because we think revascularizing these patients will result in an improvement in clinical function and subsequently an improvement in clinical outcomes. There are a significant subset of patients who do develop improvement in LV function following revascularization. But now there's a number of studies, so HEART, Part 2, STITCH, and now REVIVE, that have come to question the clinical relevance of viability in hibernation when it comes to the assessment of these patients. I'm going to defer part of this discussion to Dr. Beanlands, but I would say when it comes to Revive, I think making comments about viability and hibernation before the sub-studies are available is a little bit too premature. So we don't know how the myocardial segments that were deemed viable compared to the areas that were actually revascularized in Revive, and those results are still pending. As was mentioned before, there was a significant number of patients that appear to have coronary artery disease that was discongruent or not severe enough to explain the degree of LV systolic dysfunction. So this is also important. So I would say that the results of Revive don't necessarily negate some of the observational evidence that suggests that in patients with significant hibernation, that perhaps revascularization would be important. The other important consideration is that whenever we assess patients with coronary artery disease and left ventricular systolic dysfunction, one of the important questions is to what degree is the degree of LV systolic dysfunction attributable to the coronary artery disease. And also important to note that at present, the revascularization of patients with LV systolic dysfunction and significant coronary artery disease is still a class 1 indication for bypass and will probably continue to be so after the results of Revive. I also invite some of the surgeons to discuss the viability results of Stitch because that has also been an area for debate. So just to show you, these are the results of part 2, which again did not show any evidence in standard arm compared to the PET revascularization arm, but there was potentially a trend. And then when this was analyzed in the subset of patients for whom the PET recommendation was followed or adhered to, we do find that the outcome was significantly lower in the patients who underwent PET with adherence to the recommendation. And then even though Stitch did not show any significant heterogeneity in the treatment effect in relation to viability, we do note that patients without viability in Stitch had worse outcomes than patients with viability. And that when we look at viability testing, both in the Stitch and the Stitches arm, there could potentially be a trend suggesting improvement in outcomes with bypass in the subset of patients with viability. Again, Stitch not being a trial randomized to make this comparison based on power, but also based on the fact that viability was not required for all patients enrolled in the trial and was mainly thallium-based. I wanted to open it up for some questions and discussion.